Hello, my dear friends. Now we will continue with part 2 of the DNB paper 2. So in part 1, we saw there were questions. The first question itself was on Phyllides tumor of the breast. And then there were other general surgical mixed type of questions. Part 2, the remaining 5 questions are also similar. Some are a little weird, but overall very attemptable. And they are a little more focused. Like they are not asking you things blanket, like write a note on. They are specifying which parts are required, right? Like this question. So there are two, three more breast questions in this paper. So actually, this is a very endocrine heavy and a little bit general surgery heavy paper. So what will you see in this question? It's 6 plus 4, 10-mark question. Describe the evolving trends for localization of lump in breast. Okay, which means if I'm going to do a breast surgery and there is a lump which I can't feel clinically, then how do I localize it either preoperatively or intraoperatively so I can excise it? That is part number one. The second part is indications for MRI in breast cancer screening. This part is very easy. So the first part, when do you localize lumps? You will obviously localize them if they are non-palpable. Obviously, if it's a large palpable mass, then you will straight away remove it. But if you can't really feel it, if it was seen on some earlier imaging like a mammo or a sonomammo, how do you localize it to aid intraop accession? So if you want to divide the answer, you can do it in two parts. One is pre-op localization, which is what is commonly done. Second will be intra-op localization. Right. So pre-op, what all things we can do if we see the tumor and if it's not palpable. So one of the things you can do is you can put wires, radio opaque wires. So they are going to be inserted in the tumor. So you can put wires which are going to be put image guided. And when you are going to do the excision, you can palpate the wires and get an idea where the tumor is. This problem is it will give some discomfort to the patient. It can cause migration, the wire can get migrated because of fibrosis and all those technical problems. So if you want an easier technology, you can implant radioactive seeds which can be detected intraoperatively with a gamma camera. So this is a lot easier than feeling the wire. So you can put radioactive seeds, that is one. Second is you can put some radio tracers into the lesion. And then again, you can use a gamma probe to identify it intraoperatively. Another technology we use is magnetic seed localization. It is called MagSeed. So instead of using a gamma probe, you can use magnetic detection probe that will tell you where the lesion is. Here there is no radiation needed, and this can be inserted long time prior. And some other devices like a radar reflector, which uses infrared technology to locate the lesion. So these are all going to be pre-op, or of course you can do intraoperative ultrasound guided excision, right? That can always be done real time. So these are some of the things. For 6 marks at least I write 5 to 6 technologies which are used. That will get you at least 5 to 6 marks in this. And these are things which students would normally not be able to answer comfortably, right? They would just write mammography guided excision or things like that, but here you're getting a very precise answer. Second part is easy. Indications for MRI for breast cancer screening. And when do you normally do MRI? Two, three indications. Now, again, I've tried to give a system to the answer. First is when you are suspecting genetic or familial breast cancer. So, simple if the patient is a BRCA carrier or first degree relative is a BRCA carrier or any risk assessment model where the lifetime risk is more than 25%, like the Gale model or Claus model or Nottingham Prognostic Index, or any risk factor like a prior chest radiation, genetic syndromes like Lee-Fraumeni. So in these patients, instead of waiting for them to turn 40 and then doing screening mammo, we do screening MRI and they are going to be started at a younger age, usually by the age of 25 to 30 years, because you want to pick up the tumor earlier. Apart from this, it can be used if other imagings like a mammo gave you some discordant result, right? Or if the person is having a strong family history after a prior breast conservation, you are suspecting recurrence. So to differentiate scar from recurrence after breast conservation, or screening in women with breast implants, or for doing excision for suspicious lesions with the help of MRI. right? MRI guided biopsy, kind of like what we studied before, where we implanted some lesions where there were non-palpable lesions. So if I could not see them on mammo, I can implant some materials with the help of MRI. These are other indications for MRI. Specific to the question, point number one is the most important. Here, two parts to the question. First part is pathophysiology and management of black eye. Now, black eye normally is going to be in the setting of trauma. It will usually be due to a blunt trauma to the orbit. Okay, black eye is not trauma to the eye alone. It is a bleeding in the periorbital area. This will lead to rupture of periorbital capillaries, and the problem is the blood, since there is a lot of loose areolar tissue, the blood will track in that area, producing swelling, discoloration. Usually it will track inferiorly, so there is more blackness in the lower lid. There can be conjunctival hemorrhage also associated with the black eye. And of course, since it's a contusion, there will be color change. It will start with black, then blue, then greenish yellow, and then it will disappear over some days. But this is just the expected normal pathophysiology. There is another pathophysiology for black eye, that is if there is an ectopic hemorrhage where the injury is not to the orbit, there is a base of skull fracture, and the blood has tracked anteriorly, giving you what are called as raccoon eyes or panda eyes. Okay, so that will be bilateral, that will not be unilateral, right? So those are called as raccoon eyes. They are seen at anterior cranial fossa fractures. So they are like a marker of ectopic hemorrhage. Now they are asking you management. So management is simple. You follow the trauma pathway. First do the ABC of trauma, then assess the eye, right? So you are going to assess for fractures by palpation. Then what are you going to do? Basically, you are going to investigate to look for any fractures. So you can do X-ray, but better of course is going to be CT to rule out intracranial injury and base of skull fracture. Once other injuries are ruled out, the management of the orbital ecchymosis alone is usually conservative. So you give cold compression, you give analgesia, you can give head elevation. You may require an ophthal evaluation if the person is having visual problems like a diplopia or eyeball movements are affected, or you're suspecting a retrobarbar hematoma. And if CT showed some other fractures, they may require management. Right, especially if it's if it's a base of skull fracture like a cribriform plate of ethmoid and the person is having CSF leak from the nose, he may require a neurosurgical consult. So not all fractures and injuries may require surgery, but usually the black eye alone or the orbital ecchymosis alone will be managed conservatively.